Good
So
point.
being brave, being vulnerable. And the reason that I am so dedicated to the Emergency Nurses Association is when I started in the ER, I had been a nurse for 10 years. And I walked into my first day of orientation and they kind of knew me because I had been doing triage and they had actually encouraged me to come to the ER because they're like, all right, you've got common sense. You recognize sick from not sick, right? Like we can teach you. So my very first day in the ED, terrified, um, the nurses took me under their wing. They're like, these the most magical words any clinician can ever hear. We will not let you kill anyone.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks as always for downloading this episode and listening to the podcast. I really appreciate it. Hey everybody, Kevin McFarland here from the Art of Emergency Nursing. And in case you don't know, there are two really easy ways that you can help out the show. One is to share this show with your friends, your colleagues, people you work with, people you like, people you don't like. Sharing the show is a great way to help out the show. Another way you can help out the show is by leaving a rating and review. So if you can go to your podcast player of choice and leave a rating and a review on the podcast, that really does help the show out and helps other people like you find this podcast. If you do that, I'd really appreciate it. I have a great episode for you today. My guest today is a longtime flight nurse, longtime ER nurse, and an amazing nurse educator. She's one of the most entertaining speakers you'll ever get a chance to see. If you get a chance to see her presenting to a crowd, you will definitely not regret it. We had a lot of wisdom dropped on this episode. A lot of things, a lot of like little soundbite things. I was like, oh my gosh, this is like gold. So I think you're going to really like this episode. Enjoy this episode with my friend, Teri. Well, I'm so glad we're finally getting a chance to do this.
Me too. I'm so honored. I was texting with Cheryl this morning. I'm like, geez, I'm like, what the heckity heck are we going to talk about here?
And hopefully she was like, oh, this is easy. This is fun.
Right. She did say that. She's like, Kevin will lead it. It's fine.
Yeah.
All right. Well, Kevin, thank you so much for inviting me to this podcast. It's a tremendous honor. And I'm truly not deserving. Humility aside, I mean every word of it. My name's Teri Campbell. I am a flight nurse at the University of Chicago. And yeah, that's who I am.
All right. Now, for those who don't know, she is a very, very often a speaker at conferences all over the country. I think that's where I first seen you was speaking at the ENA conference, and oh my God, you were hilarious and funny and smart. And I was like, oh my gosh, I got to get her on the podcast.
Well,
So,
that is very sweet. I do like to dance that line of inappropriate humor, which for the national ENA, I kind of make their skin fall off their skeleton. But I like to teach to my people the way that they like to learn. And I find that most nurses, have that a little bit of jaded humor, a little bit of gallows humor, like to use the F bomb grammatically correct, as an adverb, adjective, noun, all of those kind of things. Wherever needed, as long as you put enough commas in there. So yeah, those are my people. That
yeah,
and in the pre-hospital world.
I've found the same thing, and where I think when I first started the podcast, and my wife was like, "You're going to leave that F bomb in the podcast," and I'm like, "Yeah, it'd be fine." It's I mark most of my episodes explicit, and we're not gratuitous with the F bombs, but like if an F bomb's the appropriate answer, then an F bomb's the appropriate answer. So, and I try to remember when I'm on stage, when I do presentations and stuff, I try to remember to not say stuff like that. For the most part, like sometimes it slips out, and people are like, whatever, right? I remember I was doing a presentation to a group of school nurses.
Oh,
And I'm sitting there going, okay, know your audience, right? So it's a bunch of school nurses. And we were talking, and I said, something like, oh shit, or something like that. And I was like, oh, I'm sorry, I wasn't supposed to say that. And they started laughing. They're like, Kevin, we're mostly old ER nurses. You're fine. They're like, we're all
right.
grown-ups. It's okay. So I was like, okay, good. And then we went on.
Well, I definitely, again, like all of us that have been at the bedside or stretcher side or ambulance side or aircraft side, whatever the case may be, even if it's not your out loud voice, your inside voice, sometimes when you see some of these, patient train wrecks, your inside voice is going, fuck me, because that's what you're thinking. Now, I'm not saying that it's appropriate to verbalize it, but
Yeah, it may not
that
be
is how
appropriate to say
nurses
it.
are.
May not be appropriate to say it, but you very well may be thinking it, and that's okay.
Yeah, for real.
So, how long have you been a nurse?
Oh, dear Lord, you're going to make me do math. Okay. 38 years.
That's a while.
I know it's been a minute.
In a
I
minute.
cannot believe it. Like when I say those words, I laugh because when I first started out as a wee little nurse, the nurse who oriented me had been a nurse for 10 years.
And you
And
thought she was like,
oh my God, she is like ancient. And now here I am, the old salty, almost 40-year-old nurse. So crazy.
that's right. That's right. Now, how long have you been a flight nurse?
Since 2000. So
Okay.
Long time.
Almost 24 years. Yeah.
Holy cow. It's a long time. It's a long career in flight. Now, flight seems to me like there's some people who get in and that are lifers, but there's a lot of people that kind of get in, they do it for a few years, and then they go on to other things. What made you decide to stay in that long?
You know what? I have to tell you, my whole clinical career has completely matched my ADHD personality, right? Like I went from high risk labor and delivery to ER to flight. And the reason is really pretty simple. I like really, really sick people for a very short period of time, right? I
Short-term relationship.
also, I also, yeah, I also like resolution. I love to check things off a box. And in L&D, ED, and flight, you get to do that. Patients get way better, they get way worse, they live, they die. Like there's an answer, right? My hat is off to my ICU friends that come back day after day and week after month, taking care of the same patients. Like,
Yeah,
woo, that would be tough for me.
yeah. I
So I think that's why I've loved flight. Also, my program has no specialty teams. So it is so good for my little ADHD brain, being able to take care of a micro preemie and then do an ECMO transport and then have an high risk OB and then do a peds trauma. Like I love that. I love that.
That's kinda cool. That's I think that's I think a lot of ER nurses are exactly like that, and I didn't really think about it, but OB or L&D is probably the same way. Like, they're very much in the short-term relationships too. Like, they come in, you do what you need to do, and they go on to wherever else they're gonna go. So
Yep.
that makes a lot of sense. But, yeah, I've always felt like L&D and ER kinda similar, but I I think that's the key is that short-term relationship thing. So
Right. For sure. And they, you know what, they're very similar personalities, although they love to hate each other.
oh,
And it
100%.
always makes me laugh because obviously I've been on both sides of that fence. And, you know, the personalities are very similar. Mostly it's you fear what you don't know.
100%. 100%. And I know anytime I'm up in L&D and as in my role now, if there's something going on in the middle of the night, they'll call me up there. And typically my role is simply just sitting at the desk and answering the phone and watching the door. Um, but every now and then they're like, we need your help in here. And I'm like, oh Jesus, just tell me what to do and make sure I don't touch anything I'm not supposed to touch. Or I'll walk in the room and I'll be like, I'm not supposed to be here.
Yeah, right.
They're
Walk
like,
in and you're like, is anybody else as terrified as I am right
yeah,
now?
I'm like, I'm sitting there going, I'm glad, like, and it's one of one of the clinical areas where I walk in knowing I am the least trained person at any of this. I walk in, I'm like, there's not much I can do, like I can do what I can do, but there's not much. And one day I go in there and we have a woman who is delivering and things weren't going super well. And they're like, we just need you to start an IV. I'm like, that's perfect. Love
Right.
that. Thank you. I can do that. Easy peasy.
I'm in my
Um,
swim lane.
Yeah, I'm like, "Got it, got it." Or but one day I walk in and we had the OB nurse was we had a, prolapse cord and the OB nurse was, making sure the baby didn't come out in the way that she would make sure the baby didn't come out. And, I walk in and the charge nurse is, wrist deep in this woman, and she goes, "I need you to, uh, take me to the OR, and we're working on getting the OR set up, and I need you to move the stretcher and get me to the OR." I'm like, "Done. Sure, yeah." Like, pushing a stretcher, that's me. That's me all day long. Uh, Pushed her to the OR and quickly walked out just as quickly as I could, then let the experts handle what they were handling. So,
Nothing to see here, folks. Nothing to see here.
yeah, I'm like, "All right." I walk in, I'm like going, "Oh, okay, this is going poorly. All right, okay. We can deal with this." And they're experts. They're fantastic. They're really, really good. So, but that is one area that I'm just not comfortable. And I joke with them all the time. We have the little baby button that makes that baby sound at the hospital. I don't know if your hospital does that. Um, I tell them I'm just there to push the button. That's my role. It's just push the button. And then when the sound goes off in the middle of the day and I'm out doing whatever I'm doing, I'm like, why didn't you guys call me? I would have came and pushed the button for you.
Right? You're like, I'm credentialed in that.
This is like the two things I can do is answer the phone and push the button. So
And start IVs and push cards. Don't
right.
undersell yourself.
That's right. That's right. Okay, 3, 4 things, you know. So so you went from labor and delivery to ER to flight.
Mhm.
How was that transition going from labor and delivery to ER? That had to be kind of scary.
Yeah, you know what? It's so I've told this story before, so I apologize if there's any listeners that have already heard this, but I worked at a level 1 trauma center just outside of Chicago in labor and delivery. And the emergency department had this mass exodus of nurses, which had I been a smarter human being, would have
But
been my first clue, right?
that's
So they called all the critical care areas and said, hey, we need help in triage. So let's put this in perspective. This is 1995. I was pregnant with my third kid. And at that time in emergency nursing, that's where they put the nurses that were going out to pasture because they're like, okay, triage, you can't kill anybody in triage. We now know
yeah,
triage
no.
is the most important job, and that's where you put your most experienced clinicians, right?
I remember before I was a nurse and when I was a brand new nurse, I remember them like being like, put the person who's the most dangerous out in triage. And I'm sitting there going, that's now I look at that and I'm like, what were we thinking?
Ah, right. Well, we didn't know what we didn't know.
Yeah.
So, even though people will laugh when they're like, L&D was a critical care area, that it was at my hospital because we were a high risk unit. So I was a gamer. I'm like, yeah, I'll go down. And, I quickly realized one, that 50% of the population owned a penis. And two, I did not know 95% of medicine, right? That I was very, very good in high risk OB, but I did not know rest of the world. And it terrified me. I had a stomach ache and a headache. And every time I do it, I wouldn't be able to sleep the night before. And my husband is like, why are you doing this to yourself? Like you are the queen bee in L&D. You can stay there. You've got a set schedule. Your life is wonderful. Why are you doing this to yourself? And I told him, it was because it scared me so much that I had two options. I could either turn tail and run, go back to what I knew, or I could learn.
That's awesome.
So that's what I decided to do. And whenever I meet young nurses or new nurses and they ask for any career advice, that is consistently my advice is that every time you talk to me, I'm going to push you out of your comfort zone. My husband calls it skiing over your skis, right? You're either going to ski over your skis or you're going to wipe out. But either way, you're going to get back up and you still got to get down that mountain, right?
Good
So
point.
being brave, being vulnerable. And the reason that I am so dedicated to the Emergency Nurses Association is when I started in the ER, I had been a nurse for 10 years. And I walked into my first day of orientation and they kind of knew me because I had been doing triage and they had actually encouraged me to come to the ER because they're like, all right, you've got common sense. You recognize sick from not sick, right? Like we can teach you. So my very first day in the ED, terrified, um, the nurses took me under their wing. They're like, these the most magical words any clinician can ever hear. We will not let you kill anyone.
Isn't
And
that we were talking before before I hit record, we were talking about psychological safety and how important that is. And that's a big piece of it going like, I'm not going to let you do anything bad. Like you can't, yeah, you're gonna be okay. I'm not gonna let you get in the weeds. And just telling somebody that makes a huge difference.
Oh my gosh, such a huge difference. And they literally taught me their craft. And it's because of those nurses that I am where I am professionally. And so I'm so grateful for that.
It's awesome. What a cool thing.
I
So
do
how
have a
long did
funny I do have a funny story. When I was working in the ED, I was on my orientation. I had not yet had my dysrhythmia class, right? So I mean, outside of like normal sinus rhythm, I really wasn't too competent to read anything. And I was like at the tube station mailing some blood, and I heard this alarm go off behind me. And it was VTAC, but I didn't know what it was, right? And the guy was still awake, so he had a pulse, and I remember running to my preceptor and pointing to the monitor saying, "I don't know what it is, but I know it's bad." And yes, we ran up,
like that's all you need to know?
medicated out, right? Right. So I think about that often of my humble beginnings.
It's amazing how it's amazing how much you learn over a career. You're like, oh my gosh, like I didn't know anything then.
I was talking with my son's a paramedic, and he just had a baby, so I was and his wife had a baby, so I was just over at their house, and I had him just rolling with laughter of some of the completely dumb things that I've done. So I was a nurse's aide in a hospital when I was in college, and it was a small community, very small community hospital. And in fact, the name is Holy Family, and their hiring preferential was to hire family members of employees. And it was literally, you'd go to the cafeteria and it was like a God blessed family reunion. The entire little teeny tiny hospital was related to each other. So as a result of that, I was a nursing student. My mom worked there as a nurse's aide. The nurses knew me, and so they teach me and they'd let me do stuff and things like that, right? So anyway, I was a nurse's aide. This was part of my role. They sent me down to this patient's room to do Foley care. And I don't know, the guy, I thought he was ancient, but he was probably like 45 or something, right? So I go
Amazing how
in,
that perspective changes.
right? I go in to do Foley care, and I pull back his sheet, and my eyes, I was like a cartoon character. My eyes got like as big as saucers. I look at him. I looked at his wiener. I looked back at him. I looked at him. I looked at the wiener. I covered it up and I ran out of the room. And the poor guy was probably like, "Oh my God, what happened?" So I ran down to the nurse's station and I said to the nurse, "I think you need to come look at this. Like, I think something happened with the Foley, and the Foley, like, pulled the penis in. Like, I think it like turned the penis inside out. Like it just took the inside and pulled it in." And she's like, "What?" I go, "Yeah. Like
Probably not.
I've never seen this before, but I think that this is really bad." So she came down with me. Again, the poor 45-year-old humiliated man. As we pulled back the sheet, she did a very good job containing her chuckle. And she led me out of the room and explained to me, "Teri, that's an uncircumcised penis." So little naive 20-year-old me thought that the penis turned inside out. So
That's hilarious.
now all I can think about is the great joy I have brought to nurses for the multiple times that I have been a complete and absolute ass.
Yeah, the stories you have created for
Yes.
these other nurses, right?
I,
Totally. Well, yeah, one of the things that when I was a nursing instructor for a little while I was in Houston, and one of the things that that Lisa Wolf mentioned to me, and she'd been a longtime educator forever, right? So one thing she pointed out to me that I never really thought about until she'd said it is she said, for some of these young nurses that you're going to be looking after, like this may be the first time they've seen somebody naked, like a stranger naked. And I was like, realizing to that very core of like that this is the first person they've seen naked that they didn't have intentions on being with, right? Like this very well may have been the first time they've seen someone, much older, much younger, much whatever, um, naked, and how disarming that could be, right? Like, and that how, like, just that adjustment of, you think now you're like, you see naked people and you're like, oh yeah, yeah, he's naked. Sure. And don't think anything of it. At least I don't. Like most of the time I'm just like, doesn't even faze me. Um, but for somebody who's never seen anything, you're like, that's weird. That's uncomfortable. So what a change over the years, huh?
Yeah, or just things to your point that we take for granted, like you have the gentleman that you have to put the Foley in, and he maybe has a large penis and his body habitus and maybe edematous testicles. And so you just know, you just like push the body mass back and you can find the penis, right? But like for new nurses, they don't know that.
Yeah.
And
Yeah.
I think the bigger problem that you and I have now, Kevin, you identified it. We are almost cavalier with nakedness and body
Oh,
exposure and this and that. My daughter-in-law, who I told you just had a baby. Well, like I used to teach breastfeeding. And so she's like trying to put the baby to the breast. I just like grab her boob and I'm like, okay, we're gonna do this, this, and this because I went into nurse mode.
uh-huh.
Right?
And she's like, you're my mother-in-law?
Oh my gosh. When I saw the look on her face, she was honestly grateful for the help, but I kind of jumped in like, oh my gosh, Monica, I'm so sorry. I just went into nurse mode. So yeah, I mean, I don't know if your spouse is non-medical. Mine is non-medical.
Me too.
And he hates it when a group of nurses get together, or nurses and paramedics, or nurses and residents, or whatever, because we cannot help but talk shop. And
Sure.
the more gross the story, the more embarrassing the story, the more funny the story, the more we are just like consumed with ourselves. And my husband, who used to be a federal agent, used to be a lawyer, used to be in business, blah, blah, blah. He's like, real people don't do this, right? I'm like, I don't know. I think
My
we're hilarious.
whenever somebody at a party or something, they'll say, "Oh, well, tell us what's the worst thing you've seen?" And my wife would just look at me and be like, "Don't." Like, know your audience. Like, know your
Right.
audience. And because the reality is you don't want to know about the worst things I've seen. Like, I don't want to talk about the worst things I've seen. And
Right.
and I don't want to think about that. Now, do I have some funny stories that will make you think, "Oh, he's seen some stuff?" Sure, I have some funny stories. Like, I'll share some stories, but for the most part, yeah, my wife used to be like, "Don't go there." Like, and I remember once me and my wife were talking, and I said something about seeing bad stuff and seeing tragedy and this and that, and I go, "Oh yeah, all the time." And she's like, "Well, you don't talk to me about that." And I'm like, "Well, you're not ready to hear that. Like, you're not that's not for you. Like, you don't need to know about that. That's not." And she just wants to be supportive and be there for me. But there's like sometimes you just like, I just want to come home and just not think about stuff. Right. Like I want to think about it. Can't tell you what I seen, can't tell you what I did because it's making me feel a certain way. It's damn sure gonna make you feel a certain way. Like,
I call that phenomenon explaining the Latin because, again, my husband loves me and he thinks I am the best nurse around. Of course,
of course.
he's got nothing to back that up except for the fact that he's really likes me,
Yeah.
right? Um, And I have told him before, like when I come home from rough shifts and he's like, babe, I want to be here. I want to talk to you. I'm like, I can't. Like, I need to talk to people. I talk to my son, who's a paramedic. We call each other all the time and debrief because I don't have to explain the Latin. And I told Paul, by the time I'm done explaining the Latin to you, I'm exhausted and I'm more frustrated. And right now, all I need to do is have verbal vomitus. And where my husband will be like, "Oh, but babe, you are such a great nurse. I am sure that that patient got the best care possible." Where my son will listen to my verbal vomitus and go, "Whoa, mom, that sucks." And you know what? That's all I need.
Yeah.
Just
Yeah.
I just
Sometimes it's all you
need
need.
I need him or somebody else appear to be like, "Yeah, whoa, that sucks." Like,
Yeah. That's a rough fucking day.
"Yeah, I can't make that better for you."
Yeah.
Right? And I'm not gonna give you platitudes. I'm just gonna tell you, "Better you than me, ma," you know?
Yeah. Yeah. And I think one of the things we sometimes forget to do, and it kind of depends on your relationship with the team, and for you, where you probably have a smaller flight team where you can probably do that pretty easily, where you can kind of debrief. And sometimes I feel like our in the role that I'm in now, where I'm kind of all over the hospital. um Sometimes when someone wants to debrief like that, I'm like, we can talk it out. Like, we can talk it out, and I'll, certainly be a listening ear. But we don't always give each other the chance. It's like anytime you have a code for an hour, people are like, oh my God, they're like reliving the code and going, well, we could have done this and then this happened. And they're telling other people in the team, and they're kind of debriefing without realizing that they're debriefing. Um, but that's exactly what they're doing, and then, their peers are listening and being supportive, and, hopefully listening and being supportive, and understanding what they've been through, because they've been there too. Um, where if you're not, like, for instance, say you're floated to another area, like, we had a code the other day, and we had one of the med surg nurses was floated down to the ER to help, and be helping hands. And, in the middle of the code, I'm like, "Ma'am, get ready. You're up next for CPR." And she just looked at me like, I'm like, "You good?" She's like, "Oh, I'm good." I was like, "All right." So she jumped in, did CPR, and as she was doing CPR, the doc was like, "Okay, we're gonna do one more pulse check, and if there's nothing, we're done." And sure enough, she's, doing compressions, and they stop, they check the pulse, and there's no pulse. So they're like, "Okay, we're gonna call it." And, call time of death and this and that. And she's just kind of standing there like, huh. I'm like, okay. I was like, we should debrief. Like, you're not here with your regular team.
Yeah.
You may not be able to debrief in this. That you will not debrief this to the same level that what you're going to want versus what the ER is going to do. The ER is kind of like, no, okay, let's go.
Yeah.
Who's
Let's go
next?
to lunch.
Um, but so I pulled her aside and said, "Hey, like, let's talk a little bit about this. Do you have questions? What's going on? Have you done CPR before? Have you been a part of the code?" She's like, "I've been, part of codes, of course." She's like, "But I've never done CPR." And I'm like, "It's a little different, isn't it?" She's like, "It's crazy." Like, she goes, "And to be the one who's doing CPR, and then we stop, and I was the last one to do CPR." She's like, I had a little bit of guilt about that." And I'm like, "You shouldn't." And we kind of talked that through. Um, but she may not have gotten that kind of debriefing from people who weren't her team, because they're on a different level. They're not like, this doesn't even phase me. Like, this doesn't even make my, like, this isn't even going to make the highlight reel of my day. Versus, someone who's like never going to forget this incident.
Well, I think there's a very fine line between normalizing death and becoming desensitized to death, right? So I think that is one of the places where we fail newer clinicians. Another one of my mantras is death is not always the enemy.
Amen.
And, this nurse that is feeling, oh my gosh, maybe I was responsible. My CPR wasn't good enough to bring Lazarus back from the dead. Um, so kind of being able to pull that camera back and be like, oh, we coded. I mean, the fact that you just said they coded somebody for an hour, I'm like, ugh, like what realistically, unless you have refractory shockable rhythms,
Yeah.
neurologically that patient is
Yeah. You're not.
devastated,
Yeah.
right?
You're like,
So yeah, kind of pulling that camera back. And then the opposite extreme is that desensitization. So of course, we have to have some way to compartmentalize, right? Otherwise you can't do your job. You can't fall apart every time.
yeah.
But you don't want to have that desensitized response when it's a 4-year-old that comes in and has a code, right? Like
It's different.
the 94-year-old from the nursing home that's had a wonderful life that, like had a syncable event in her 100-year-old birthday cake. I'm high-fiving her, right? She's partying all the way into the next life. When you've got that 4-year-old and you're like, "Okay," wiping your hands on your scrubs, and you're like, "Hey, did that Chinese food come?" Like, "Hey, is anyone" that we have to be able to recognize that in our peers. That
Like,
shit's not right, right?
yeah.
You might not feel all the feels, but
You should feel
you
something.
should be feeling some feels,
Yeah.
even if it's anger. Like, there should be some feels there. And
Gotta be something.
I think that as good team members, as good peers, as good friends, as good coworkers, you got to be looking out for your buddy. You got to be looking out for your enemy, for God's sakes, right? Like if if people are having these detached responses, they need some help. Maybe they need some time away. Maybe they need some professional debriefing. But that kind of compartmentalizing, that crap's gonna come squishing out somewhere else, right?
Gonna come
Maybe
squishing out
it's
somewhere else. That's a great way to put it. It's gonna come
yeah,
squishing out somewhere else.
it's gonna. Like that pressure cooker, like you can only squeeze Play-Doh down so hard and it is squishing out and it's not gonna be pretty.
Yep. Yep. I remember my first pediatric death. I remember, in the room and the nurse, was, very emotional. She was the nurse that I was working with. I was a tech at the time. I was an EMT tech at the time in the ER. And the nurse I was working with was very emotional and very, all the things, right? Like, still love her to this day. Um, and she was very distraught. She was like, "Oh my God, this is really sad," because it was a very young child. And I was kind of like, "All right, let's move on with this. We're good. Like, okay, we're done. Let's get ready for the next." And kind of cavalier and kind of a little like, this is sad, but like we got shit to do, right? Like, and then I remember like kind of like just kind of denying myself those feelings in that moment. And then, a few minutes later I go out into the ambulance bay, and we had a little shed in the ambulance bay, and I was back behind the shed, where people used to go to smoke back in the day. And I remember just sitting there and I just started bawling. Like it all just like hit me like a freight train. And here I am, like literally bawling and behind this shed in the ambulance bay. And this woman, Katie, I'll never forget Katie, who's about 80 years old and about 4 foot tall. And she just comes and puts her arms around me and just hugs me. And she's like, "I wish I could tell you it gets easier, but it doesn't always get easier." She's like, "There's always hard cases." And she's like, "You get better, but it doesn't get easier."
Mm.
And I sat there and just cried like a baby in Katie's arms. And one of the one of the paramedics that was kind of known for kind of teasing people on being a little bit of a jokester and being a little bit of a, sometimes a little cruel. kind of turned the corner and he's seen that this is going on. And here I am like weeping like a baby in, Katie's arms. Right. And I'm sure he'd like just kind of seen us and like realized we were having a moment and walked away. And I was like going, oh my God, he's going to tease the shit out of me about this. And, and he, just later that day when I see him, he's like, hey man, you good? I'm like, better. It's like, if you ever want to talk, gives me his number. Goes, you ever want to talk? He's like, been there, done that. And, it's got to come out somewhere. Like it's going to come out. You just got to make sure that like it's coming out in a healthy, productive way. So do you remember the last code that really kind of made you like emotional and like,
Hmm. We had a 13-year-old girl that we were called to the outside hospital, and she was probably in extremis, but she wasn't coding when they called us to do the transport. So we knew that she was a really, really sick patient. And you know what? Again, I'm trying to remember it. I think she had coded pre-hospital. They got her back. She was ROSC, but was unconscious and still critically ill, right? So by the time that I walk in to do the transport, she is coding again, right? And they had been coding her for like, 40 minutes straight or some crazy amount of time. And um, it was really tough because the staff was crying, right, as they were working this code. And so one of the things that I really try to teach the nurses that I fly with is that our brains are fresh. We are not emotionally down the rabbit hole yet with this patient.
yeah,
So we are the ideal person to be like, okay, what are the H's? What are the T's? What has been done? What needs to be done? And kind of take over that leadership of that code, right? And working with the referring doc and stuff. And we ended up calling the code, and it was hard for me seeing how hard the staff that were there, how they were taking this. It's always, listen, every ER nurse out there has heard the wail
mm.
that has seared into the brain and the heart
I
of,
just got
of
chill
parents.
when you said that. I just got chills down my body
Yeah.
because I know that all too well.
Yeah. So we ended up getting the post on her, and she ended up, interestingly, her only risk factor is I think she was on birth control pills for dysmenorrhea. And she had, and I am not on this podcast saying that birth control pills are causing these things, please. There was like an 8 centimeter clot in her PA.
Holy cow.
So this was a non-survivable code, right?
Yeah.
And again, the BCPs might have had nothing to do with it. She had had a minor fall downstairs like a couple days prior, but like, who knows? Yeah.
Yeah. And it's got to be hard as a flight nurse, like even for experienced ER nurses. When the flight nurse comes in, you're like, going, "There's the savior. There's are the folks.
Yeah.
Those are the guys that are going to get our dick out of the dirt and help us out." And really, sorry, that was a really crude thing
No,
to
I
say,
love it. And
but
it's true.
it's when the flight team comes in, like I know I've always felt that way with the flight teams I've worked with, like those are the best of the best of the best. And they come in and you're like going, okay, if anyone's going to be able to help us out here, it's going to be these guys. And sometimes you're like doing
Yeah.
everything you can.
That honestly, that's it, for anybody who's listening to this podcast, that would be my 2 cents of advice. I mean, we appreciate the compliment, but we're also not miracle workers, and we don't want to mismanage expectations for parents or family members. In fact, there's been unfortunately multiple times where I've said, you need to come give smooches. You need to say, I love you. You need to do all of these things because I don't know if your loved one is going to survive this flight, right? And when it's kind of set up that, oh my gosh, Marvel superheroes are here and they're going
Yeah.
to save the day, you're like, ooh, dude, like,
Dude, we're just wearing a different uniform.
yeah, I can't sign that check, right?
Yeah.
So that is really tough. But I think the the hard part that we have as clinicians is, again, like, to be a nurse, you have to have so much finesse. You have to be smart AF, right? You have to be savvy. You have to be a politician. You have to be a priest. You have to be a counselor. You have to be a cop. You have to be a parent. You have to be all of these things,
Mm.
right? And again, so much of our career is fine lines. Like, another fine line is not taking away hope and devastating people, but also being realistic, right? And I saying the words, I don't know what's going to happen. I can tell you, while your child is in my care, your child, my hands will always be on your child. I will whisper to your baby how much you love them. I will keep them safe. I will keep them warm. I will do everything medical within my abilities to get that baby to the next hospital safely. But I need you to know, as a mom, that I'm also a mom, and that I am telling you, I am going to love your baby like you are, like you do. And I always give them a hug. I give the parents a hug, because if that baby doesn't make it through that transport or through that hospitalization, like, I want them to know. I want them in their grief process to know that their baby wasn't alone, right? And that somebody was loving that baby. Now, Kev, you find, I know the reality is, somebody who's actively trying to die, your hands are doing a lot of things, right?
You
Drawing
know?
up beds, hanging blood, putting warmers on, adjusting the vent. Like, you're
Yeah.
doing a lot of things. So my hands are not, they're usually on the child, not always in loving ways,
Yeah.
therapeutic ways. Sometimes they're in medical ways. But that spirit of that love is 100% there.
Yep. Everything we do is out of that love for people and for just in general, especially when you talk about peds. So, man,
Yeah. I worry about the nurses that don't feel that way anymore. Burnout is a real thing. Again, cliches, of course, burnout is a real thing, and often well deserved, right? Patients are really sick. We're very understaffed.
yeah,
Patients and families can be assholes, right? Not being politically correct here.
it's true.
There's a lot of lateral violence with our peers. So again, kind of before we started recording, we were talking about demanding a culture of psychological safety,
Love
demanding,
that.
actively slugging your way through to say to your peers, dude, that's not cool. Like, you can't talk to people that way. You can't talk to your peer that way. You can't talk to the resident that way. Like, we need to be together as a team. So, but that takes buy-in from every team member. That takes people saying, okay, I'm getting off this merry-go-round. This is cray-cray. I don't want to be here. I want to be someplace else, right? But that culture breeds that culture. Bacteria breeds bacteria. So unless we do something to change that dynamic, then you can't blame your work environment. You gotta, yes, everyone has some accountability, but you're part of that puzzle.
Yeah. why do you think we get like that? I mean, why is it's unfortunate that that's sometimes the stress response is. The stress response is like, I'm fucking stressed out, I'm over the top, I'm burnt out, so now I'm gonna be just an ass to everybody. Like, why? I
Yeah.
don't I do a bullying lecture, a nursing instability lecture, and one of the things I talk about is how ironic it is the nurses are the most trusted profession. They're, often voted the most trusted profession. Yet the most common thing you hear about nurses is that we eat our young. And it's not just our young, it's our old, it's our young, it's our slow, it's our different, it's our, anybody who is maybe a little bit different or maybe in a different place. Um, why do you think that is? Like I've never understood that as, some of the most loving, caring people I know can be such rotten bitches.
So I think that's a multifactorial answer, right? So I'll just spit stuff out and I don't know, maybe some of that'll stick. Um, the first thing that comes to mind is think about a marriage, right? Your When my husband was like, he was working as a federal agent, he was going through law school, like so many stressors, but he was holding it together, right? Because he had to be well behaved at work and he had to be well behaved at school. And then he'd come home and he'd lose his meconium because I didn't take the kids to a birthday party, right? And I was the safe person that he could blow off at. Now, listen, that did not work out well. And there were lots of conversations about that until that behavior changed. So, part of it is I think that there may be a lot of stressors at work and at home and this and that. And so maybe these are your safe people to blow off on. That's number one. Number two, um, when you don't feel appreciated and you don't feel supported and you feel like the care you are giving is baseline dangerous, that's not why any of us went into this career.
Amen.
So I think that nurses feel like, wait a minute, I went into this to give good care and I'm not allowed to give good care. So that contract is now null and void. And so I don't have to be nurturing Nancy Nurse because you didn't hold up your end of the contract, like providing me an environment where I could give safe care.
Yeah.
I think that has something to do with it. The third thing is, you know what, Kevin, your mom and your wife was right. Bullies, the more bully you are, the more insecure and weak you are. Think about all your clinical role models, right? The people that really own the knowledge, that really own the skills. They were never the jackapples because they were confident. They knew their stuff, right? I think some of the new younger nurses come in and they've got a knowledge base that some of the older, saltier ADHD nurses like me maybe don't have, and they're threatened. And so it's a way to stomp them down. And like you and I had mentioned maybe before we were recording, like, I don't know why it is, but the most brilliant, wonderful nurses I work with all suffer from imposter syndrome.
100%.
Okay? And so think about this. You're a newer nurse, or maybe you're new to a department, and maybe you were pretty cool in your old role, but now you're skiing over your skis, right? And now you've got all kinds of trepidation. And when you've got other nurses there that are telling you, girl, I have forgotten more than you'll ever know, you start believing that.
Yeah.
So you have to pick the press that you're gonna listen to, right? If you're gonna listen to that press, that's gonna feed your narrative that you are an empty suit, right? So The other thing that I really like to tell kind of emerging nurses is I am a huge fan of professional fantasies. Like every time you're in the car, every time you're in the God bless the car, turn the radio off and have a professional fantasy. You are the one that discovered the med error before it was given. You are the person that realized the doc read the 12 lead EKG wrong. You are the person that safely delivered that baby while hanging upside down in a, sunroof of a car, right? Like it doesn't matter how ridiculous it is. Because you know what? The more professional fantasies you have, guess what? That becomes the news you listen to. That becomes your narrative.
One of the things I always try to do is whenever I see a nurse make a good save or like a good catch or, anything like that, where you're like going, holy shit, that could have been really bad had we done that. But you caught it. You caught it and you noticed that we didn't do this. Like I make such a big deal about stuff like that. And like I'll talk about it for days. I'll be like, oh my gosh, this is Sharon. Sharon's the one who caught this. Oh my gosh. I'll tell people that story all week long. And part of that is lifting people up when maybe they don't feel like a rock star, but you're like going, dude, you were a rock star in this moment. Like, and don't forget that. And I think, giving people those props when you can and build them up when you can, I think goes a really long way. So,
I think assuming positive intent also, again, I'm throwing out a lot of cliches. I'm sounding like a Hallmark commercial, but again, mom was right.
yeah. Yeah. So, holy cow, this has been good. It's been a lot of fun.
It has been.
Covered a lot of ground. Holy cow.
We did. And you're right. It was way less scary than I thought it was going to be.
Yeah. So one of the things I tell people all the time is like, this is just us, sitting around talking shit, talking shop. As you said, we'd love to talk shop, right? And get a group of nurses together, and this is exactly the kind of conversation they're going to have. So, but which is what I love about the podcast, and what really sparked the idea for the podcast was just that. Like we were at ENA leadership, and I was there with a group of nurses, and we were all talking, and I was like, this would be a good podcast. Like a new nurse should be able to listen in on this conversation and be like, oh, okay, all right, we're going to learn a little something here today. So, but holy cow. Now, are you ready for the hard questions?
Oh, geez, Louisa. Where do babies come from? Well, a mommy and daddy love each other very much. Then a stork comes.
Speaking of, and I can't remember what the quote was, but so at the last ENA conference, I was sitting with a table of people, and I don't remember what exactly we were talking about, but they said something about, they were talking about sex. I don't know why we were talking about sex. Honey, please don't listen to this. I was talking about sex with a table full of women. And they said something about Jabu or
Gina?
No, it's
Oh, Jabu?
Jabu. Yeah, Jabu. They said something, and they mentioned your name and said something about Jabu, and I was like, I don't know what that is. What are you talking about?
So I don't know. That may be two different stories. So I do talk about Jabu, and I have to give props to my school wife when I got my master's, Jen Rocha. She's in New York City now. Whenever we'd have to take a test, she'd be like, T, we got to offer it up to Jabu. I'm like, Jabu? And she's like, yeah, Jesus, Allah, Buddha, and the universe. Like, we got to pass this test, right?
Okay. Okay.
Oh, I don't know if that's what you were talking about with sex, but
It must have been. It must have been.
maybe, I don't know. The pelvic, the big vagina that I carry with me when I teach across the country.
Huh?
Her name is Vagina Lokia, and she's this great big vagina, and she lives in a black box. And when I travel, I have to take her to the airport, and it's listed as fragile and medical device. And so they always ask me, they're like, any lithium batteries, any of this, any of that. And I'm like, nope, nope, everything's good. And I don't offer information. And they're like, well, what is it? And I go, oh, it's a medical model. I use it for teaching. And they go, oh, what is it? And I go, do you really want to know? Because I'm going to tell you. And they're like, yeah, now you've piqued my interest. I want to know. I go, it's a really big vagina. I go, do you want to see it? And they go, no. Oh, God,
You
no.
want to? I just see you asking a stranger. Do you want to see my really big vagina?
Oh my gosh. I kinda laugh on, like they say that cops have a throwaway gun. I've got a throwaway vagina. But I've kind of learned something through all of this stuff with TSA. If I ever decide that I'm gonna be a drug mule, all I have to do is bring vagina. And because nobody wants to see her big vagina, which I think is sad. She's lovely. And she's taught a lot of people how to birth babies.
That's pretty awesome. That's pretty awesome. Yeah, I remember hearing about a class you did where you had a camera on your head and you were doing deliveries or something. I was like, I would love to see that. That'd be amazing.
Yeah, it was really fun. It was, BC before COVID. It was at National ENA and I had a GoPro. And so I would bring people up from the audience. I would talk them through how to do different deliveries and then they would do the deliveries and everyone in the audience could see it. So it was a fun lecture.
That's awesome. What a cool way to teach it. How cool is that? Well, I think I've seen 2 of your talks, and I can't remember one of them. I can't remember exactly what it was about, but the last one that you did in San Francisco, where you were talking about celebrity deaths and what actually killed them, that was fascinating. I was like, "Oh my god, this is amazing." And that's when I was like, "Oh, I gotta get her on the podcast."
Oh, thanks.
So, all right, the last question I always ask people is I always ask people a question called 3 things, and it's a question of what are 3 things a new nurse should always remember, and what's 3 things they can just forget?
Mm,
It's a tough one.
this is a tough one. 3 things you should remember. I'm gonna slaughter it, but the Winnie the Pooh quote about how you're smarter than you think and braver than you think, kinder than you think. That's the first thing. The second thing is from the book The House of God, which is a super old book and a quick read. I think everyone should read it.
Amen.
Um, the first thing you do in a code, take your own pulse.
Oh,
Right? You're alive. You got this.
yep.
Um, the third thing every nurse should know is you are a beautiful, smart work of progress. And each experience, good and bad, is going to sand off those edges and make you a better and better clinician and hopefully a better and better person. But you have to be willing to grow, right? You have to be willing to grow. Okay, 3 things people can get let go of. Bullies. Bullies are bullshit. So let go of them. 2, hmm, if you didn't chart it, you didn't do it. That's also bullshit. There's a lot of things you do in your clinical practice that are part of your clinical practice that don't end up in the electronic records, so don't worry about that. Um, 3, that you're not the smartest person in the room. You don't know that. There's a lot of hot air around us and a lot of bravado that may not be warranted. And You may very well be the smartest person in the room. If something does not seem right, if something doesn't feel right, honor that gestalt because you just might save your patient's life.
Good point. It's a good point. And even whether you're the smartest one in the room or not, you may be the one person that has that unique perspective that says, wait, this is all wrong. This is all not the way it's supposed to go. It's kind of intimidating when you look around and you think to yourself, gosh, I might be the smartest person in this room. And 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 then there's times where you're looking around and you're like, I'm clearly not the smartest person in this room. But whether you're the smartest person in the room or not the smartest person in the room, everybody's got something to offer. And man, you got to speak up if you see anything that you're like, that you question. I love that. It's great advice. It's been a lot of fun, Teri.
It has been fun. I just wish that we had some beer in front of us. Next time we should do it with cocktail in front of us.
Right? We I always say, we're one of these days I'm going to do this as a live, and we're just going to sit around and drink and tell stories. So I don't drink, but I'll watch you guys drink.
There you go. Well, we need somebody to drive us over.
That's right. That's right. So this has been a lot of fun. I really appreciate you taking the time to do this with me.
Oh my gosh, thank you so much. And I wasn't kidding. It's a tremendous honor. I really appreciate this.
Oh, it's the honor is all mine.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.